Great. And now I would like to turn it over to my colleague, Janine Kuzma, for some brief introductory remarks.
Thank you, Kyle, and good morning, everyone, and welcome. And thank you for joining us today to our St. Joe's Aging with Insight series. My name is Janine Kuzma, and I am the Senior Manager of Gift Planning here at St. Joseph Health Center Foundation. Today's topic is cognitive health and aging, and I am thrilled to have with us our St. Joe's expert, Dr. Amanda Chen. Dr. Chen presented on this popular topic last year, and thanks to a wonderful feedback we received from you, we decided to invite her again. And I'm happy to say we have over 800 people registered for this session. Before I ask Dr. Chen to join us, I would like to extend our sincere thanks to the Slate Family Foundation, whose generous support and commitment to seniors' health has made this series possible. I would also like to take a moment to acknowledge the land on which St. Joe's operates. This is a traditional territory of many First Peoples, including the Mississauga of Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Banded peoples. Today, this land remains home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered Treaty 13 with the Mississauga of the Credit. Before we get into today's presentation, and while we are still waiting for people to join us, I would like to share something with you. You all know our West End community is rapidly growing. Today, serving 500,000 people, the demands for more specialized medical services and more spaces are growing fast as well. Thanks to the incredible generosity of our donors and support of our community, we have been able to create state-of-the-art spaces that enhance care for everyone. Those spaces include St. Joe's bigger and better emergency department. This extensive renovation and expansion marks the largest fundraising project in our hospital history. And I'm thrilled.
Janine, Janine, you've been muted. Can you unmute?
This is thanks to the incredible generosity of our donors and supporters of our community, we have been able to create new state-of-the-art spaces that enhance care for everyone. Those spaces include St. Joe's bigger and better emergency department. This extensive renovation and expansion marks the largest fundraising project in our hospital history. I am thrilled to share that this transformation is now complete, featuring 40% more space, advanced technology, and specialized zone designed to improve care for our patients when they need the most. This is one of many incredible examples, and what makes it even more remarkable. This is one of many incredible examples that makes this even more remarkable is that this project was funded 100% by donors. Thank you for your generosity and for sharing this vision of extraordinary St. Joe's. But as always, we still have much more to do and exciting plans for the future, including expanding key areas such as our ambulatory care department, surgical spaces, and mental health care programs. If you'd like to learn more about our exciting plans or make a donation or include us in your estate plan or in your will, please connect with me. My contact information will be on the screen at the end of that presentation. Now, without further delay, I'd like to introduce to you Dr. Amanda Chen, geriatrician here at St. Joe's. Dr. Chen completed her residency and subspecialty training at the University of Toronto. She's passionate about caring for older adults and has interest in medical education. She is a master's health profession education candidate at Maastricht University. Welcome, Dr. Chen.
And sorry, Amanda, just before you start, I'll remind people of a few housekeeping notes as people are arriving. Please make sure to mute your microphone and turn off your video. We will be periodically muting everyone, but it also means then that we mute our speakers. So if you can help us out by making sure you're muted, it'll keep background noise to a minimum and make it clear for everyone. Thank you very much. And with that, we'll hand it over to Dr. Amanda Chen.
Thank you so much, Kyle. Can we go to the next slides, please? I just want to thank everyone for the kind introduction, and thank you so much for having me back. For those of you who have joined the talk last year, there will be some similarities, but I have added additional points based on feedback I received, as well as frequent questions that I received throughout the past year. To give a brief overview of our talk, I will be reviewing the aging process, what changes might be considered normal in aging. We'll be talking about some potential red flags that might prompt seeking of medical attention. We will look at the disease spectrum in terms of changes in our brain health. And then we will also, I'm so sorry. Kyle, can you please? Can everyone hear me a bit better now?
Yes.
Okay, thank you. And then we will be discussing some preventative strategies as well as future planning. Next slides, please. When we look at the aging process, this is a dynamic process that is really impacted by a variety of factors: biological, physiological, environmental, psychological, behavioral, and societal factors. So our actual age, yes, it is a number, but the aging process can be slowed by taking steps and efforts to support our health. Next slide, please. This is a brief table when we look at cognitive changes that can occur with aging. The left side. I'm so sorry. Can everyone hear me again?
Yes.
Yeah? Okay, my apologies. When we look at the left side of the table, we can see different aspects of our brain health that can have some slight decline as we age. When we look at the right side of the table, this is where our brain health functions are preserved. So over time, as we age, there can be a gradual mild decline in what we call processing speed, our reaction time. So for example, when someone all of a sudden throws a ball at us, how quickly can we react to that and catch that? Our attention span can be diminished slightly, and as well as there might be some very slight short-term memory loss. So what I mean by that is when we walk into the kitchen trying to think about, oh, I want a glass of water, we might forget about that for a second, but then it quickly comes back to us after a minute or two. In terms of aspects that are preserved in our brain health, our delayed memory and our visual memory are preserved. So when we're trying to recall information or events that happened minutes ago, hours ago, as well as our visual memory, so our looking at visual images and processing that, that's preserved. Our language skills, our knowledge base that we have retained over the years, that is maintained as well. We continue to be able to learn new information as we age. Yes, it might take us a little bit longer to remember that information or learn that new information, but eventually we will be able to learn. When we look at procedural memory, So things that we have always done throughout our lives when we perform different tasks or different procedures, whether that might be related to our prior work, that is maintained as long as our physical capabilities are maintained. Next slide, please. This is a simplified diagram of our brain. The left side of the slide is the front of our brain, and the right side of the slide is the back of our brain. In our brain, there's a variety of different lobes that helps us to have different types of function and cognitive function in our brain. When we look at potential red flags, either concerns that we ourselves raise or loved ones or family members that raise, this is when we start to notice, is there either a gradual steady decline or an accelerated decline that is when we might look for additional medical attention. So for example, when we look at the front aspect of our brain, the frontal lobe, this is the part of the brain that is responsible for the higher complex aspects. So organization skills, problem solving, planning, having complex conversations with your family or loved ones. Are we starting to develop more difficulty engaging in those conversations? Is it becoming much more complex that it's difficult for us to understand? That might be out of keeping of normal aging. When we look at the temporal lobe, we might notice, is there a gradual decline in short-term memory loss? Either things that we learned or information that we talked about earlier in the day or the day prior. Are we experiencing increased repetition where we might ask the same questions over and over again? Are we misplacing items that we are common things such as glasses or our wallets? Are we misplacing them throughout the day? Then when we look at the parietal lobe, our occipital lobe, this is the center where we perceive visual imaging and process our sensory information. There is cognitive change that can happen. It is quite rare, but are we starting to not be able to pick out what the item that we need in a box of drawers? So is there difficulty with processing that visual information? Next slide, please. Kyle, I just want to let you know, I think Gina is not able to get the audio, if you could help her with that. Thank you. In terms of thinking about seeking medical attention, it sometimes can be a little bit difficult knowing where do we start when we start to notice that either ourselves or loved ones are experiencing change in our brain. I always recommend first, if we can please try to book an appointment with your family doctor. I do recognize that many individuals may not have a family physician. This is where we might need to seek attention at a walk-in clinic. So discuss your concerns with your family physician or a walk-in physician. They might review your medical history. They might do cognitive testing as well as a physical exam. Then they might do some additional blood work, additional brain imaging, and rarely we might do some procedures as well. They might talk with you about referring to a neurology specialist, a geriatric specialist, or a psychiatry specialist to further look into that concern or that memory change concern so that we can have a better diagnosis and reach that. Next slide, please. I hope to share a trajectory or a spectrum of the aging process, as well as the disease spectrum from the left to the right. So from the left is subjective cognitive impairment, mild cognitive impairment, as well as the different stages of dementia. I will talk about these individually. Next slide, please. When we look at subjective cognitive impairment, this is when we ourselves over time notice that I am experiencing some cognitive change that didn't seem to be there 5 years ago, 10 years ago. When we seek medical attention, when we do cognitive testing, do the blood work, do the brain imaging, there's no objective findings. This is in that category. So someone who is starting to notice a little bit of change, but we continue to perform very well in our day-to-day life. Next slide, please. When we look at transitioning to what we call mild cognitive impairment, this is where either ourselves or our family or loved ones start to notice that a gradual cognitive decline. And when we then seek additional attention, there is some objective changes that we notice now on cognitive testing. However, at this stage in time, we continue to perform our day-to-day function very well. What I mean by that is the things that we have always done earlier in our lives, cooking, cleaning, paying our bills, all of those things, if we had done them earlier in our lives, we continue to be able to do them as long as it is not a physical, I cannot move my arm or I cannot walk very far, for example. Okay. Next slide, please. When we look at loved ones living with dementia, the transition occurs when the cognitive impact or the cognitive decline is now affecting the things that we used to do day to day all the time. We are now having a little bit more difficulty. In mild dementia, we continue to perform a lot of things by ourselves independently, but we might start to need either friends or family or loved ones to help us with what is considered more complicated tasks in our life. So, for example, paying our bills every month, remembering the financial statements, or cooking is also a multi-step component task. Next slide, please. In moderate stage dementia, the condition is now impacting a bit more in our what we call instrumental activities of daily living if we look on the left bottom box. What that means is the safety in terms of driving or navigating directions, cleaning our house, meal preparation, paying our bills, and financial management. We start to have a bit more difficulty in this category, but we continue to perform what we call activities of daily living quite well, most of them. What that means is our basic things that we have to do throughout the day, grooming ourselves, toileting, bathing, or dressing ourselves. Next slide, please. In severe stage dementia, most of our day-to-day function now requires the assistance by others or loved ones. So they might be helping us with bathing, dressing, and toileting. Next slide, please. When we look at the brain disease, it's a brain disease called dementia. This is an umbrella term. There are then a variety of subtypes of dementia. And here I've listed some of the more common subtypes: Alzheimer's, vascular, mixed, Parkinson's or Parkinson's plus, and frontotemporal. I'm going to be talking a little bit more about Alzheimer and vascular, which are the two most common subtypes. Next slide, please. Alzheimer's dementia is the most common type of dementia. It accounts for about 60 to 80% of all subtypes. This brain disease is where our predominant decline that either ourselves are noticing or our family and loved ones are noticing is short-term memory loss. So, for example, mom and dad used to be very sharp. We are now experiencing increased repetition, increased forgetting where we place things, conversations that we had earlier today or the day before. We don't really seem to be able to remember or recall that anymore. Next slide, please. Vascular dementia is the second most common type of dementia, and this tends to occur for different ways. Number one, it can occur after a large stroke that impacts our brain function in that area of the brain where we had the stroke, or it might be a gradual accumulation of tiny strokes or increased vascular burden in our brain. The main focus when we look at vascular disease is managing and controlling our vascular risk factors at our young age and our middle age. So, for example, managing our blood pressure, our cholesterol, our diabetes. So those are the most important things when we look at prevention of vascular dementia. Next slide, please. When we review the potential risk factors for dementia, there is actually about 45% of the risk factors can be preventable. So this is a new slide from last year that came out when we looked at the studies. When we look at risk factors, hearing loss is an important risk factor. So we receive information from the outside world through our eyes and through our ears. If we are now not able to hear that information or stimuli over time, we start to block information out from the outside world. The other things to look at is cholesterol we talked about, increasing socialization with either our loved ones or the community. Those are important risk factors. There are other ones listed on the right side, a little bit smaller, are physical activity, diabetes, smoking, etc. Next slide, please. When we then look at prevention strategies, here are some strategies that are helpful and evidence-based. We hope and try to exercise at least to what we call moderate intensity. So that's where we're exercising for 20 minutes, 25 minutes if we can, and we might be a little bit tired, we might be a little bit sweaty at the end of it. This might be aerobic exercise, resistant exercise, or mind-body exercises. Next slide, please. When we look at our diet, eating healthy, and specifically we recommend a Mediterranean diet, where throughout the day we increase our vegetable and fruit intake, add a bit of olive oil if we can. Next slide, please. When we look at engaging in what we call cognitive stimulating activities and lifelong learning, this will help to maintain and preserve our brain function. So participating, if we can, in activities or social activities or recreational activities periodically with our friends and family. Next slide, please. I hope to also talk a little bit about future planning and supports, because as we age, there may be a decline in both cognitive and physical aspects of our health. And how do we support ourselves or loved ones when we experience this? The majority of us may wish to stay at home for as long as possible. On the left side, over time, our friends and family and relatives, they might be able to help with certain tasks to support us, such as bringing in groceries, helping us with driving us to different appointments, for example. Eventually, we may look at applying for OHIP-covered government-based home care supports. This is where our nursing staff or personal support worker staff, they might come to your home and they might help you with things like bathing or dressing or toileting. It is not a perfect service, but it is something. Then we might look at, depending on individual circumstance, because everyone has different personal circumstances, we might talk about hiring private care to come into our home or potentially moving into a retirement home. A retirement home is a facility where we might live in, and it can accommodate a lot of supports from our nursing staff or PSW staff there. But oftentimes the main limitation is the cost, because most of that is privately paid. We might also think about early on applying for long-term care. This is a healthcare facility that we might live there when we get older, and there is on-site nursing and PSW staff at all times. I think one important consideration for long-term care is that there is a wait list after we apply. So that's why planning forward and planning for the future might be important. Many of us also may have had discussions with our loved ones about power of attorney. And I always think I always encourage this and think this is an important topic to discuss, even though it might be a hard topic to talk about. Because then when we are well cognitively and physically, we have the opportunity to designate who we would like to help us with medical or financial decisions in the situation that we're not able to for a variety of different reasons. Next slide, please. These are some resources and some additional education materials that I thought might potentially be helpful. But I'm also here to answer any questions. I left lots of room for us as well. Thank you so much for your time. Kyle, I'm going to give it back to you.
Thank you. Perfect. Thank you so much, Amanda. That was a great presentation. I know I learned a lot and to think about, and there's lots of questions that have come in. So I will jump right to them. Just another housekeeping reminder, if you can keep your video and microphones off and use the Q&A function or the chat function, that'll be great just to help with bandwidth and so everyone can hear. So the first question that we have, please educate us on the difference between normal age-related cognitive problems versus dementia-related problems.
Yeah, thank you so much for that question. So one of our slides earlier on, we talked about, yes, as we age, there are some changes we might notice. There can be some very mild short-term memory loss, very mild, decreased reaction time, decreased attention span. But the things that we always done in our lives, we should still be able to do them. So because of our memory loss, it's not affecting our day-to-day life. We're still able to know where our wallet is, know where our glasses are. We still remember to take them outside when we go out for a grocery trip, for example. So it's not affecting at any aspect how we perform our daily lives. In loved ones who may experience the disease called dementia, this is where our brain function has been declining and it continues to decline over years. And then at some point, it starts to impact on our ability to remember to bring our wallet out when we go grocery shopping, or we cannot remember conversations that we have had with our loved ones or our children earlier in the day, for example. Yeah, this is where it's starting to impact on our function.
Thank you. And maybe related to that, there's a question from Anjna. Is there a way an individual can know that there is mild cognitive impairment, and what should one do? Oh, you're muted.
Thank you so much. That's a great question. So I always share that this is a group effort, both from you, yourself, your loved ones, your relatives, as well as medical geriatricians or neurologists or psychiatrists. We are the most, I would say, common specialties that look at brain-related changes and brain-related health. When you have a concern, what will usually end up happening is you might bring your attention to your family physician, for example. Then you might see a geriatrician or a neurologist. We will oftentimes be performing cognitive testing. We will ask you, unfortunately, our appointments are quite long. So our appointments are usually 1.5 to 2 hours long. So we will delve into a lot of details around what are the symptoms that you've been experiencing over the years. We will look at cognitive testing. We might order some blood work, order different brain imaging. All of that together ends up helping us coming up with a hopefully accurate diagnosis, whether that might mean mild cognitive impairment or dementia or neither of the above. So I always share, if there is concerns that you're noticing in yourself or loved ones, please don't hesitate to reach out and look for an assessment. Yeah.
Thank you. Next question is from Christine. Do you recommend that mentally sharp people get assessed before they become impaired So there's a baseline or like something that they can be compared to what used to be.
I think that's a good question. That's that's a really good question. I don't know if I have the right answer for that. I think if you're cognitively sharp, you continue to be able to work on strategies to improve your health, exercise, socializing, eating well. I don't know that you necessarily need to have a cognitive baseline, but or a cognitive testing documented. But if it's something that would make you feel more like it might help you feel a peace of mind, or it might be helpful for you, particular for the specific individual, then I think it might be a worthwhile appointment. Yeah, it's not usual, but yeah.
Thank you. And there's been a number of questions that have come in from people about crossword puzzles. And so I think asking about, do crossword puzzles, games, computerized cognitive games, can that help, stop the progression of impairment?
It's a great question. I think what I always share with my friends and my family and my patients is I don't want you to force to do anything that you like absolutely hate or really don't like. So if crossword puzzles is not your thing, I don't want to force anyone to do that because there are so many other cognitive stimulation strategies that can be helpful for our brain. I would like to find something that is suitable for this particular person. So if you're someone that has always enjoyed crossword puzzles and likes doing that, I think absolutely please continue because that's one of your hobbies. If you don't and really don't like it, I think socializing or recreational activities or bingo or exercise, we can find other things that are suitable for someone who might not enjoy crossword puzzles.
That's great. Thank you. There's a question from Janet in terms of vascular dementia, or where vascular dementia is concerned, is low blood pressure the same concern as high blood pressure?
It's a really good question. So I think it depends on the specific condition or disease that you have that's leading to low blood pressure. If we're thinking about, so blood pressure typically for an individual might be somewhere between 120 over 80 to 140 over 90. That category may be considered normal depending on age and your circumstance. If your blood pressure is consistently, let's say 70 over 40 or 60 over 40, most people will start to feel a variety of symptoms, dizziness, lightheadedness, falls. In those aspects, if someone's blood pressure is persistently very, very low, yes, it can affect our brain. The reason I say that is because our brain also needs our blood vessels to provide blood into our brain. So if our blood pressure is very low, we might have some difficulty for the blood to go up into the brain. And if that's also persistent over months or years or many years, depending on what that the condition is, yes, it might impact our brain health. I think most commonly, if someone's blood pressure is very, very low, 70, 60s all the time, most people will experience other symptoms first before they experience brain like cognitive change. They will feel very dizzy, very lightheaded, for example. Yeah.
Thank you. There's another question from Ulupi. I heard low cholesterol causes dementia. Is that true?
So cholesterol, we look at vascular risk factors. So it also, again, I cannot give a generalized comment. The reason is because it depends on your medical conditions. So for example, for someone who has had a stroke in the past or has had a heart attack in the past, it is very important to bring down the cholesterol level, or what we call the LDL level. Typically, our goal is 50% or more drop compared to our baseline, or less than 2. However, in someone who has never had those stroke or heart attack in the past, their targets might be a little bit different. Yeah.
Thank you. There's a question from Jean. Are there any medications that can help with memory loss?
Yes, so in mild cognitive impairment stage, our strategies is predominantly non-pharmacological. In loved ones who experience mild stage, moderate stage dementia, we will be discussing potential medication trials for your particular loved ones. It's a long name, I'm sorry. The most common medication class is what we call acetylcholinesterase inhibitors. There's three sub medications in this family. We might talk about that. We might talk about other medications as well. There are many, many medications that are currently under research that is not yet available in Canada right now, but we're hoping in the next 5 to 10 years, there might be some changes to that as well. Yeah, so there's a lot of novel medications that researchers are looking into. Mhm.
Great. And I mean, maybe related to medication, but a bit more broadly, there's a question from Carol of what treatment options are available to slow the rate of dementia.
Yeah, so typically right now in Canada, the typical medication trials would be a pill format. It most commonly it's a tablet or a pill that you will take every day. Some individuals we might use a patch if they cannot tolerate the pill. Mhm. But that's the most common type right now. Um, Again, in the next 5 to 10 years, we might see some changes with that. Mhm.
Thank you. We have a question from Adina, wondering starting with what age is considered geriatric care?
So most of my patients will be 65 years old and higher. Um, I always, similar to what I shared in the beginning of the presentation, age is a number. So we might be 65, but we might experience a lot of medical conditions that require geriatric care. We might be 85, but we are very healthy and taking one or two medications. So I think age is a number, but typically I see loved ones who are 65 and older.
Thank you. We have another question from Jean. Um, I'll just kind of read verbatim. Could you please comment on how the elderly, for example, my 95-year-old mom, who is Chinese but fluent in English after living in Canada for 70 plus years, defaults to their native language when they are communicating when distressed or excited?
So language skills is and can be a change that happen over time with aging. And more significantly, it might be a precursor to mild cognitive impairment or dementia. But I think it really depends. So if, for example, if I'm someone that speaks both English and Mandarin, over time, let's say I still speak English and Mandarin very well, but it's only when I'm excited, it sounds like, or angry that I revert to Mandarin. I don't think that necessarily considers a big change. Versus if I'm someone that speaks English and Mandarin very well, but over time I'm losing my English abilities and I'm reverting to Mandarin skills. For me, it's actually probably the other way around. But regardless, if I'm reverting and it's a big change that's consistent over the course of months or years, that may be a sign. But if it's only when I'm excited or when I'm angry, like temporarily, that may not be an issue. Mhm.
Thank you. So we have another question from Santa. How can one assist a loved one who is in denial about the changes they are experiencing?
It's a very tough question. Yes. I think I see loved ones similar to that in my clinic as well. I think I always encourage myself as well and family and loved ones to start with this is the reason why we're concerned is not because we want to nitpick someone's cognitive ability or we think someone is declining cognitively. The main reason why we care about this is how can we care for this person better? How can we care for this person safer? And how can we make this person as healthy as we can be? So I think perhaps trying to have a conversation with your loved ones that this is the predominant goal is really not because I feel like this person is losing their memory, like because they might be experiencing that themselves and they might have insight to that. So I think coming together with a goal that the predominant reason why we care about this is so that we can better care for your health, to better make sure you can live well in the community for as long as we can, and starting from that. But it is very hard. I'm sorry, I don't have a great answer to that.
No, and thank you. And I imagine it's such a personal, experience that it'd be so difficult to have those conversations, and it would be so personal to each person.
Yeah.
Do you know, are there, maybe I'll just build on it, are there resources in the community that are more like emotional support than necessarily like medical support for people that are either experiencing dementia themselves or loved ones or caregivers of someone with dementia?
Yes, that's a great question. Thank you, Kyle. So for example, there in the Greater Toronto area, there's a center called the Reitman Center, Reitman. It's based at Mount Sinai Hospital. At this center, the main predominant concern or the main support that they're giving is actually not for loved ones living with dementia. It's for loved ones who are caring for people living with dementia. So they provide caregiver support around either educational talks, around either counseling or social work supports, for example. For example, at our clinic at St. Joe's, we have 2 social workers that predominantly only work with our geriatric population and patients. So they're a huge help to myself and my colleagues around helping our loved ones and families live well at home. Yes.
Thank you. There's a couple of questions sort of in this vein. So I'll read one from Adriana. Is there any specific like blood work or even more invasive tests that can reveal if a person would be more susceptible to developing dementia?
So no. So the quick answer is no. Most dementias are sporadic, most of them. There are some very rare dementias that are genetic, but those would be typically loved ones who are experiencing dementia diseases as young as 30 years old or 40 years old. So as we grow older over time, the prevalence of loved ones living with dementia increases. So typically between 65 to 75, there might be less than 5 to 8% of the general population, 75 to 85, a little bit higher, 10 to 15, and then 85 to 95, a little bit higher than that, 15 to 20%. So typically most dementias are sporadic. The rare ones where our generation above or the generation above us are experiencing dementias at a young age of 40s or 30s, that might be potentially, we might have genetic counseling to look for particular genes.
Thank you. There's a number of questions about, and not surprised by this after your presentation, but a number of questions about how people might be able to see you or book an appointment with you, if that's possible, and if you only see patients that are experiencing dementia.
That's a great question. Thank you for asking. So I work with a number of wonderful colleagues in our clinic. They are all geriatric specialists as well. So we will ask for a referral from either your family doctor or your walk-in doctor to refer to us. I do not only see loved ones living with dementia. I commonly see loved ones living with dementia. Some of the other things that we will also look at is geriatric symptoms that may happen when we get older. So falls, many medications that we're taking every day, what is important, what is not. So polypharmacy, falls are also big components of my practice. Yeah.
Thank you. I see there's another question from Sudentia, asking if chronic loneliness or even like regular intermittent loneliness can be a risk factor in dementia. And they're flagging, especially the type of dementia in the umbrella slide that you talked about.
Yeah, so that's a really good question, especially we've noticed, and during the pandemic, for example. So during the pandemic with COVID and a lot of isolation strategies to try to combat that piece, we've noticed. So the issue with loneliness is loneliness may lead to decreased socialization. Loneliness may lead to we are spending a lot of time at home, not interacting with our family or loved ones, or going out to the community to talk to our neighbors or community programs, which are good for our brain. Therefore, over time, it may start to impact on our brain function. One other thing that loneliness can sometimes lead to, not always, loneliness may sometimes lead to when we spend a lot of time in our home, not really interacting with others, it might impact on our mood. So anxiety or depression might impact on our cognitive health. It's not a specific subtype of a risk factor. So loneliness by itself is not a specific risk factor for any particular dementia, but it may lead to dementia. The way we help to diagnose different subtypes of dementia is really by a really detailed history, which is why our appointments are kind of long. Cognitive testing, examination, a neurological exam, as well as brain imaging. So usually it's those 4 to 5 factors help us come up together to a big picture of what we're looking at or what disease we're looking at. But yes, we have noticed that unfortunately over the pandemic. Yeah.
And maybe a follow-up part to that is how would one like create strategies to sort of cope or overcome with that?
Yes, that's a great question. So I think this is an individualized personal question and answer. So the reason I say this is every person is unique and different. So what might work for me may not work for you. But if you're looking at increasing socialization and stimulation activities, I think looking at this individual's hobbies and interests, are they potentially interested in joining a community program where we might do chair exercises once a day? Are we potentially interested in joining a bingo program at the community center? So our social workers work really hard to help loved ones find that interest for that particular person, so that we can start to increase that social engagement for them as well. There are many in the community that we don't always realize that they're available. So that's where our social workers have been really helpful.
Great. And there is another question, and maybe as you're talking about, talking to social workers and finding about the resources. So question from Christine. What is the expected wait for a referral to visit? If someone wanted to visit your clinic, is it looking at a few months or a year or?
Yeah, so depending on your area and where you live, so for example, at St. Joe's, we have our geriatric clinic. Other hospitals also have wonderful geriatric colleagues as well. So the wait list might differ depending on which hospital you're looking at. Right now in our hospital, the geriatric clinic, I think it's a few months. So it's not very long.
Thank you.
Which is great. We've worked really hard to decrease that.
That's great. Yeah, it sounds like you and the team work so hard. So
no,
thank
no,
you.
our colleagues are really, really good.
I have a question from Deborah, and I will just flag that we have about 10 more minutes left, so we'll maybe take another couple questions and then start to wrap up. And just want to say thank you, Amanda, for taking the time to go through everyone's questions and answer this. Really appreciate this time. So a question from Deborah: is it true that forgetting the name of an item is a natural part of aging, but forgetting what the item is a symptom of dementia?
It's a really good question. So forgetting the name of an item, so word finding difficulties. For example, sometimes I might be trying to tell you a story about an airplane and I can't remember the word airplane all of a sudden, but I can tell you, oh, you know that thing that flies in the air. So a little bit of word finding difficulties might be within the realm of normal aging. Significant word finding difficulties where I am now having a lot of trouble finding my words may not be normal. So I think it depends on the degree of that aspect. The other type that you had shared, thank you, is what we call semantic knowledge. So the knowledge of an item. I'm looking at a TV remote. I don't know that it's a TV remote. I don't really know that what this is used for. That's losing the knowledge base of that item is what we call semantic knowledge. That may be abnormal, yes. So over time, that is a very rare type of dementia that we may call primary progressive aphasia. I didn't list it in the more common types up on the slides, but that might be abnormal. So yes, I would recommend having an additional look and medical attention with that.
Thank you. I think this will be our last question, and then we will wrap up the presentation. And this question is from Elaine. Do you know if there are any studies being done on 90 plus people with no cognitive issues? And what, if anything, is different from maybe that group and other seniors who are maybe experiencing cognitive issues?
That's a really good question. Off of the top of my head, I'm not sure about any exclusive studies of only 90 plus, but in our geriatric studies, yes, there are loved ones who may include 90 plus. That is happening consistently. When we look at 90 plus, I think the main thing to know is recognizing our body is changing as we age. So sensory-wise, vision and hearing and our physical capabilities may change. So when I try my best to assess loved ones who are 90 years old and older, recognizing those changes and how can I try to eliminate those factors during my assessment. So for example, for us, if someone is having hearing impairment, we might use a pocket talker to try to optimize that. So recognizing there are differences that can happen as we age, but to the best of our ability to try to eliminate those other factors that might be distractive, so that we can actually look at someone's cognitive health. I would say as we get older, because the prevalence also increases for dementia, so when we look at 90 years old and higher, about 20% of loved ones in the general population may be experiencing dementia.
Great. Thank you very much, Amanda. We really appreciate the presentation and you taking the time to ask all of these questions. It's obviously a lot of questions flowing in, so it's a topic people are very interested in. So thank you. We will wrap up the Q&A there. Just a reminder to folks that we will share the recording of this and the slides on the website after. And I will pass it over to Janine for sort of closing remarks. And one last thing from me, if people are in the chat, and we really appreciate that. And so it'd be great if you kind of help us out and add any topics that you'd like to hear about in the future. We really want to make sure that these presentations are informative and helpful to you. So if there's topics that you're interested in hearing about, that would be great. And with that, let's say thanks, Amanda, and hand it back to Janine.
Thank you, Dr. Chen, for a very informative and, as always, great presentation. And thank you, everyone, for joining us today. And of course, my apologies for technical difficulties. The good news is that you can always count on St. Joe's extraordinary care. The next visual presentation in Aging with Insights is coming up in the spring. And for more information, visit us at supportstjoes.ca/agingwithinsight. Thank you again and have a wonderful day. And of course, don't hesitate to contact us with any questions and feedback. Thank you.